My name is Dr. Patrick Schoenbachler, and I'm the Site Training Director of Sovereign Health in Phoenix. And this presentation is entitled, What Works in Therapy? 65 years ago, in 1952, Hans Eysenck, a psychoanalyst, published a review of 24 studies concluding that psychotherapy was not only ineffective, but potentially harmful. The conclusions provoked considerable public and professional attention and were immediately disputed by proponents of psychotherapy. 54 years ago, in 1963, Hans Strupp, a German-born psychoanalyst who was one of the pioneers of psychotherapy research, published his own critique of Eysenck's research. Strupp critiques was entitled The Outcome Problem in Psychotherapy Revisited. And he blasted Eysenck's methodology and conclusions and offered his own recommendations for effective psychotherapy research. Predictably, Eysenck wrote his own rebuttal to Strupp's comments, which he branded as irrelevant, incompetent, and immaterial. This was then followed by Strupp's response, in which he pointed out that the controversy about the value of psychotherapy has been with us for some time and is not likely to be resolved by argument or by counter-argument. So what's happened over the past 50 years? In 1967, membership in the APA stood at about 22,000. The Diagnostic and Statistical Manual was in its first edition and was 130 pages in length and listed 106 mental disorders. Treatment modalities numbered fewer than 40, and psychoanalysis and psychodynamic models predominated the field. 50 years later, in 2017, the APA membership stands at about 77,500. The Diagnostic and Statistical Manual, now in its 5th edition, has reached an astonishing 947 pages. The Substance Abuse and Mental Health Service Administration, their website lists 145 manualized treatments for 51 of the 297 mental disorders that the DSM now categorizes. The principal disagreement between Strupp and Eysenck is resolved. The efficacy of psychotherapy is well established, and so is its effectiveness in real-world clinical settings. Despite the consistent findings substantiating the field's worth, significant questions remain unanswered. Principally, how does psychotherapy really work? Before examining how psychotherapy works, let's review the debate's resolution between Eysenck and Strupp. And we'll ask the question, does psychotherapy really work? Over the past 50 years, research has consistently demonstrated that psychotherapy across populations, age, gender, and diagnosis has a large and consistent effect size. Effect size refers to the magnitude of change attributable to treatment, either by comparing the clinical status of a treated sample with that of an untreated sample, or by comparing a sample's clinical status before and after treatment. Study after study and studies of studies show the average treated client is better off than 80% of the untreated sample. Psychological interventions provide substantial improvements in functioning for people with a variety of mental disorders, ranging from depression, panic, and bipolar disorder to performance anxiety, public speaking, and alcohol addiction. Those who receive psychotherapy achieve much better outcomes than they would have had they not received psychotherapy at all. In clinical trials, psychotherapy has been shown to be effective in treating depression, anxiety, marital dissatisfaction, substance abuse, health problems including smoking, pain and eating disorders, sexual dysfunction, and with various populations, including children, adolescents, adults, and the elderly. So why is psychotherapy effective? In 1936, the American psychologist Saul Rosenweg coined the term the Dodo bird verdict. It was to illustrate the notion that all therapies are equally effective. Rosenweg borrowed the phrase from Lewis Carroll's Alice's Adventures in Wonderland, wherein a number of characters become wet and, in order to dry themselves, the dodo bird decided to issue a competition. Everyone was to run around the lake until they were dry. Nobody cared to measure how far each person had run, nor how long. When they asked the dodo bird who had won, he thought long and hard and said, "Everybody has won and all must have prizes." In the case of psychotherapies, Rosenweg argued that common factors were more important than specific technical differences, so that, on the dodo bird conjecture, all therapies are winners. They all produce equally effective outcomes. The dodo bird debate only took flight in 1975 when Lester Luborsky reported the results of one of the first comparative studies demonstrating few significant differences in the outcomes among different psychotherapies. This study spurred a plethora of new studies in both opposition to and support of the dodo bird verdict. The dodo bird debate, in brief, is focused on whether or not the specific components of different treatments lead some treatments to outperform other treatments for specific disorders. Supporters of the dodo bird verdict contend that all psychotherapies are equivalent because of common factors that are shared in all treatments. That is, they have a relationship with a therapist who is warm, respectful, and has high expectations for the client's success. In contrast, critics of the dodo bird verdict would argue that specific techniques used in different therapies are important, and all therapies do not produce equivalent outcomes for specific disorders. A meta-analysis of outcome studies comparing bona fide psychotherapies by Bruce Wampole and his associates tested Saul Rosenweg's dodo bird conjecture. The findings were that the effect sizes of the studies that were compared were not related positively to publication date, which means that improving research methods were not detecting changing effects. Secondly, they were not related to the similarity of the treatment, indicating that more dissimilar treatments did not produce larger effects if the dodo bird were in fact false. The evidence from Wampole's analysis supports the hypothesis that the effectiveness of bona fide treatments are all roughly equivalent. And that was a rather astonishing. Wampole's meta-analysis has been replicated by a number of other researchers. And today, the American Psychological Association acknowledges both evidence-based psychotherapies as well as the equivalency of psychotherapies in their effectiveness to treat various mental disorders. So now the question is, why does therapy work? There are two schools of thought regarding why psychotherapy works. There is the specific ingredients model and the general or common factors model. The common factors theory proposes that different approaches in evidence-based practices in psychotherapy, these share common factors that account for much of the effectiveness of a psychological treatment. In contrast to that view, the specific ingredients model states that the effectiveness of psychotherapy and counseling is best explained by specific or unique factors within the theory. that are suited to the treatment of particular problems and populations. Specific ingredients model relies on randomized controlled trials, describes specific therapy ingredients within each theoretical and therapy orientation, relies on effect sizes to determine the effectiveness of individual therapies, and states that therapies are either compared to a wait list, untreated population, or pre and post-treatment differences. The common factors model utilizes meta-analyses of bona fide treatments for specific disorders, looks for common factors to account for the variance of treatment outcomes. And study after study and meta-analyses have produced a small or non-existent difference among therapies. Research strongly supports the hypothesis that bona fide psychotherapies are generally equally effective. The conclusion: there is much greater support in the research literature for the efficacy of common factors as conceptualized by Rosenwig in 1936 and by others after him than there is for specific treatment effects on which the empirically supported treatment movement so much depends. Therapy works due to a core of general therapeutic factors. If we break down these factors, they fall roughly into two categories: client factors and treatment effects. Client factors include the client's readiness for change. We have all experienced people who have come for therapy and they were made to come either because of court-ordered treatment, perhaps they were having marital problems and their spouse wanted them in treatment, or they would file for divorce. Perhaps it was at Chandler we have a number of clients who come to us because their parents have decided that they can no longer keep them and are insisting and demanding on treatment. So the client's readiness for change is a critical factor. If there's significant resistance, or if the client does not want therapy, if they feel that their lifestyle or their behavioral patterns are acceptable to them, they are not ready for change. So readiness for change is a very key and critical factor. It's estimated that client factors account for 80 to 87% of the variability in scores between treated and untreated populations. Another client factor is client strengths. If clients recognize their strengths, they're more likely to have a better outcome, therapy outcome, than if they do not recognize their strengths or believe that they don't have any strengths. Clients' resources, including social network. Clients that have community and have a sense of belonging to a group of people, these clients tend to show better outcomes in therapy than clients who tend to isolate and withdraw and are very much alone. The client's premorbid level of functioning, that is the functioning before treatment, is also critical. The higher the premorbid level of functioning, the better the therapeutic outcomes. The client's socioeconomic status is another critical factor, as well as the client's personal motivations. And finally, life events. The time of life and the life events that a client is currently experiencing seem to have an impact on the outcome of psychotherapy. Treatment effects are the second broad category of common factors. Treatment effects include therapist effects, those characteristics in a therapist that promote therapeutic attachments and bonding, and that make one therapist more effective than another. The alliance between the therapist and the client is a second factor. Expectancy of the client as well as the therapist, and the allegiance to methodology and to treatment protocols are also very powerful determiner for the outcome of therapy. And finally, techniques and methods are part of the treatment effects. So let's look at the treatment effects. The first one is therapist effects. Research shows that who provides the treatment is an important source in outcomes. Research demonstrates that some psychologists and clinicians are more effective than others, and we all have experienced this. We know that some therapists, irrespective of education, are much more effective than other therapists. So it turns out more effective therapists and psychologists form better therapeutic relationships with a broader range of clients. 97% of the difference in outcomes between therapists is accounted for by differences in formation of the therapeutic relationship. The general rule of thumb is that human relationships harm us and cause us difficulties, malfunctioning, maladaptive behaviors, and human relationships are what heal us. The formation of therapeutic relationship is critical for therapeutic outcomes. And interestingly enough, age, gender, years of experience, professional discipline, degree, training, licensure, theoretical orientation, amount of supervision, and use of evidence-based methods had little or no impact on therapy outcomes. And that to me was a startling finding from the research. Alliance. The therapeutic alliance is a consistent predictor of psychotherapy outcomes. The relationship between therapist and clients is the single largest factor in determining the outcome of therapy. The research indicates that by session 2, the therapeutic alliance needs to be formed in order to have significant therapy outcomes, positive therapy outcomes. If that relationship is not formed, and if there is not an alliance between the therapist and the client, therapeutic outcomes are significantly diminished. The alliance works by engaging the client in the treatment process, by doing such things as listening intently to the client's presentation of the problems, giving back to the client an understanding of his or her problems and the difficulties that have brought them into therapy. A clear communication that the therapist is confident that an alliance can be formed, a treatment plan can be put in place, and that the therapist has the tools and can share with the client the tools and the therapeutic feedback necessary for positive outcomes. All those factors engage the client in the treatment process. It builds confidence in the client. Research shows that the client level of engagement is the most robust predictor of change in therapy. Expectancy and allegiance. These factors refer to both the client's and the therapist's expectations and beliefs about the therapeutic process and the possible effects of therapy. If the therapist does not believe that therapy is going to be effective, or if the client has significant doubts about the therapeutic process, positive therapeutic outcomes are diminished. From the client's side, these effects refer to hope and expectations about healing in therapy, and more specifically to the client's belief in the therapist and the treatment the therapist provides. Once the client has confidence and belief that therapy and the therapist are effective, therapeutic outcomes, positive therapeutic outcomes, increase. From the therapists, these effects include positive expectations that an alliance and a relationship can be formed, a firm belief in the therapy process itself, and a belief in and allegiance to the approach and model used for a particular patient. Model, technique, and theoretical orientation. Studies indicate that a lack of structure and focus in treatment are robust predictors of negative therapy outcomes. The fit of the model or the technique to the client's preferences and expectations are also salient in fostering improvement in therapy. This speaks to the idea that one size does not fit all. One particular therapy or therapeutic orientation does not fit all of our clients. Some clients are going to require other interventions, other therapies that will prove more effective than others. Patients who are borderline or obsessive compulsive, have severe interpersonal difficulties, are poorly motivated, or who expect psychotherapy to be painless have been found to be at risk for deterioration and negative therapeutic outcomes. For therapists, lack of empathy, underestimation of the severity of the patient's problems, negative countertransference, poor technique, high concentrations of transference interpretations, and disagreement with the patient about the therapy process have all been shown or associated with negative therapy outcomes. So what makes for an effective therapist? What makes one therapist more effective in treating clients and patients across the board from another therapist? What are those qualities and skills and characteristics that set a therapist apart? We'll look at these in a future presentation. Thank you for your time, and thank you for listening.